Yeah, very good afternoon, everyone. I would like to acknowledge that most of these slides have actually been made by Dr. Mahendrapal, and I'll just be speaking on his behalf. So this is the paper that we've been tasked to discuss. Upfront cytoreductive nephrectomy for metastatic RCC treated with immune checkpoint inhibitors or targeted therapy. It's an observational study, multicentric study. So this paper in the introduction went about discussing the history of cytoreductive nephrectomy and the Carmina trial. So we'll just go over it quickly. So in the targeted therapy era, this paper was published in 2014. It was a retrospective analysis of CN versus no CN in metastatic RCC. And the targeted therapy was sunitinib. And there was a definite survival benefit with cytoreductive nephrectomy, but no benefit if 4 or more IMDC risk factors were present. And around that time, cytoreductive nephrectomy followed by targeted therapy was the standard of care, but all this data was probably retrospective. And that is why the Carmina trial was run, to prospectively check if there is a benefit of cytoreductive nephrectomy along with sunitinib or not. It was a multicentric RCT with 450 patients, and most of these patients were intermediate risk and poor risk patients, almost all of them in fact. And these were the location of mets that they had. At a median follow-up of around 50 months, they found that sunitinib alone was non-inferior to cytoreductive nephrectomy followed by sunitinib. And that is why that was their conclusion. So with that paper, what happened is we stopped doing cytoreductive nephrectomy for all our metastatic RCC patients. And that paper was done with sunitinib, and over the last few years, we've had a lot of more therapies that have been available. So we compared sunitinib with sunitinib and surgery, and on the other hand, the systemic therapy was only getting better. So there was in fact some evidence, or it was our thought, that with the systemic therapy getting better, is the role of surgery going to go down even more? So is there no role for cytoreductive nephrectomy? The paper also goes on to say that in a post hoc analysis of Carmina, they found that for patients with 2 or more IMDC risk factors, that is intermediate risk patients, the OS was significantly longer with sunitinib alone. But for patients who had only one IMDC risk factor, that is intermediate risk, but only one IMDC risk factor, the OS was longer for CN. So why this study? So the role of upfront cytoreductive nephrectomy for metastatic RCC in the era of immune checkpoint inhibitors is unclear. We don't have any evidence for this. The objective of the study was to examine the benefit of upfront cytoreductive nephrectomy in metastatic RCC patients receiving either targeted therapy or immune checkpoint inhibitor. So they checked all of this. It was a retrospective multicenter study. So we had 2 groups, one receiving targeted therapy, which was sunitinib, and one receiving immune checkpoint inhibitor therapy, which was mostly EP plus Nivo. Each cohort was further divided into those who had a nephrectomy and those who did not have a nephrectomy. The primary outcome was overall survival. They did a lot of statistical analysis. So for the survival, they did the Kaplan-Meier analysis, which is routine. But since it was a retrospective study, to combat the biases that can happen in a retrospective study, they did inverse propensity of treatment weighting to balance the biases. And they also did something called as multivariate confounding score to evaluate whether the observed associations were sensitive to unmeasured confounding factors. They have described this in the paper. I have not been able to understand it. So these were the results. They had in excess of 4,000 patients. When we see ICI, that is immune checkpoint inhibition, 430 patients. So a minority were only ICI patients. Majority of patients were still the sunitinib patients. And as you can see, about half the patients had a nephrectomy and half the patients did not have a nephrectomy in both groups. The patients in these groups, for patients who underwent a cytoreductive nephrectomy, majority of patients were in the intermediate risk group in both groups, the targeted therapy group and the immune checkpoint inhibitor group. Whereas patients who did not have a nephrectomy, more than half were the poor risk patients, which seems pretty logical because that would have been the decision for those patients. They did a multivariable regression analysis, and they found that for less likelihood of receiving a CN, these are the factors that they had. So older patients, patients with mets in brain, liver, and bone, a low performance score, and poor IMDC factors, these patients were more likely to receive a cytoreductive, were less likely, in fact, to receive a cytoreductive nephrectomy. Now, what about the primary outcome? The primary outcome was to compare overall survival amongst patients who had a nephrectomy and who did not have a nephrectomy. So in the group of patients, the 400 patients who received immune checkpoint inhibitors, the patients who had a nephrectomy, their survival was significantly longer than patients who did not have a nephrectomy. In the patients who had received targeted therapy, the other 4,000 patients, the patients who had a nephrectomy, their survival was significantly longer than patients who did not have a nephrectomy. Now we may say that this is all retrospective. Obviously the patients who were anyways better biology, they had a nephrectomy, so they had better survival. So to combat this, they did some inverse propensity of treatment weighting, and this yielded similar results. So they tried to nullify the bias, and they still found that patients who underwent a nephrectomy had better survival compared to patients who had the systemic therapy only. Some strengths of the study: large study, multicentric cohort, and whatever possible could be done to remove the bias in a retrospective analysis was done by them. The limitations are that it's retrospective after all, and they could not have adjusted for some confounders like patients getting a nephrectomy for symptoms like hematuria or flank pain, underlying medical conditions like CKD, and the extent of the local disease. Another limitation is that they only included patients who had a nephrectomy upfront. They did not include patients who were first started on the systemic therapy and then had a deferred cytoreductive nephrectomy, which has kind of become the norm for us when we are treating our intermediate risk patients. So it cannot tell us whether upfront is better than delayed. This paper is only telling us that upfront is better than not doing the surgery. So does it mean that we should be doing surgery and Carmina was flawed? So let's go back to just discussing a few points about Carmina. It included only intermediate and poor risk patients, whereas this study had good intermediate and poor risk patients. For Carmina, the accrual was very slow and they did not even reach their planned accrual. And there were considerable shorter OS in Carmina compared to all the retrospective evidence that was available till then. Another shortcoming of Carmina was the median size of the primary was 88 mm and the median total tumor burden was 140 mm. So only half the tumor load in the body was actually contributed to by the kidney, and that is why the benefit of cytoreductive nephrectomy was not very apparent in such patients, and those receiving systemic therapy had better survival. So to conclude, upfront CN should not be overlooked, as this paper says, and it has a significant better survival regardless of whether you're going to use a targeted therapy or the immune checkpoint inhibitor. But you should not be doing it for all patients, obviously. Younger patients with fewer IMDC risk factors, no adverse metastasis, and better performance status are more likely to be benefited. And you'll get the best results if you do it on the right patient, at the right time, and the right place. So you need to select your patients properly. So this paper is probably just adding on to what we actually do. It is giving us some evidence, first time some evidence, that even in the setting of using immune checkpoint inhibitors, the IMDC risk stratification can still be used. Our poor risk patients, give them the immune checkpoint inhibitors. Intermediate risk patients, stratify. And for the good risk patients, we're anyways doing a nephrectomy for them. Yeah. Thank you.